Yeah, okay. Good afternoon, ladies and gentlemen. I'm Chae, working for Seoul National University Hospital. So, in this session, the title is EVAR, TEVAR, and Peripheral. So, my co-moderator is John Laird. We have distinguished panelists, Seok, Lawrence Garcia, and Chung-Ho, and Young-Guk and Yoon, Hyun Park, and Jae-Hwan Lee, and Yoon. Yoon is not available right now, so because he's trying to finish the last live demo patients. We will have a lot of topics. So it's very time is very limited. So we're gonna start the first lecture. And the first lecture is the title is Pathology of PAD: Implication for Device Based in the Medical Therapies. So will be presented by Aloke and Finn. Dr. Finn, please.
Thank you so much. Appreciate it. Here are my disclosures. You're all familiar with this, but the prevalence of peripheral arterial disease by age and outcome, really you see here on this graph that the prevalence really increases dramatically with age, and really the rise is more marked in high-income countries and low-middle-income countries. And the prevalence of PAD in women was greater than that for men in many of the age ranges. But you can see that PAD is a fairly prevalent disease, and we should expect to see it in a fair number of our population as the population ages. So this talk is about pathology of PAD and what is really known here. PAD is primarily caused by atherosclerosis or thrombotic occlusion of arteries that supply blood to the lower limbs and associated microvascular dysfunction. Pathology studies of human arteries show, as you're all familiar with, atherosclerosis has progressive stages involving lipids, muscle cells, inflammatory cells, all those into the lesion. And the plaques advance through things such as cap thinning, necrotic core expansion, inflammatory cell infiltration, leading to plaque rupture, in some cases erosion. But most of the work that's been done understanding the pathology of atherosclerosis has been done in coronary arteries. We're very familiar with the mechanisms of plaque growth and expansion, but its relevance to PAD really remains unclear because there's a lot less studies done in PAD. There's only very few histological studies and on samples of peripheral arterial disease, and no report really has described serial sectioning of pathologic characterization of PAD. And before I get to that pathology study, I just want to say that PAD and CAD, are they the same disease? Do they have the exact same causes? That's really something very interesting, frankly, and you can get this through genome-wide association studies. Really, this was 19 PAD loci were found after analysis in the Million Veteran Program. This was published a couple of years ago in Nature Medicine. And some of the loci that were found overlap with coronary, cerebral, and peripheral. And these are really lipid-related genes that abnormalities in those genes suggest these targets as therapeutic for all three atherosclerotic phenotypes. But some variants are exclusive to PAD, and a lot of those have to do with, for instance, thrombotic effects. Factor V Leiden is a variant which seems to increase PAD by 20% at least, with more severity in carriers, increased risk of undergoing PAD-related major amputation. So if you have Factor V Leiden, you have a risk of PAD-related major amputation. So this is back to the pathology now. In this study, we did 12 legs from 8 cadavers through a science care donor. And these were subjects greater than 70 with multiple risk factors. We basically chose arteries with calcification to enrich them for PAD. And we excluded people with lower extremity interventions. We basically dissected the arteries along their entire length. And some of them were decalcified using paraffin sectioning to look at these arteries, and some were actually not decalcified to leave the calcium intact, and we did what's called a resin embedding and thick sectioning of these arteries. You can see here the types of plaques we found. They resemble the plaques found in coronary arteries. You can see the progression is very similar in terms of we saw fibroatheroma, thin cap fibroatheroma, ruptures, healed ruptures, all the things you would see in a coronary tree you might see in peripheral vascular disease. But now we divided these in terms of the type of plaque above the knee and below the knee. Left is above the knee, SFA popliteal, and right is below the knee. And what you really see here is that you see that plaque types were significantly different above the knee and below the knee. Atherosclerotic lesions such as fibroatheroma, pathological intimal thickening were more common above the knee than below the knee. And acute thrombotic plaques were really exclusive to above the knee. They were not seen really below the knee. Now we looked at why vessels occlude, both above the knee and below the knee. In these samples, we had 5 vessels, 8 lesions with occlusion and above the knee. And those above the knee lesions with occlusion had either underlying rupture, plaque rupture, or calcified nodule, both well-known causes of thrombotic events. Below the knee, really only 5 of the 10 lesions that were occluded had atherosclerosis underlying them, whereas 5 of them were presumed to be from distal emboli because there was no underlying atherosclerosis, but there was a CTO seen. This was essentially seen similarly in another study done by Narula's group, where pathology of PD presenting a patient with CLI amputation data. This was 121 amputations from 95 patients. And in this particular study, you can see that, interestingly, whether there was stenosis was greater than 70% or all stenosis, insignificant atherosclerosis was much more common below the knee than above the knee, whereas atherosclerotic lesions were more common above the knee than below the knee. So that's one important message. The other message is that medial calcifications seem to be somewhat more common, extensive medial calcification below the knee than above the knee. And when we looked at chronic thrombi with its significant atherosclerosis, as I repeated before, really below the knee was where those lesions were seeing, whereas chronic thrombi with significant atherosclerosis were really more common above the knee. This was similar to what we saw in our own study, where we eventually saw more atherosclerotic lesions above the knee than below the knee. Stenosis was generally greater above the knee than below the knee. Intimal calcification was was greater above the knee than below the knee, whereas medial calcification really was not different, and I'll go into a little more detail between that. Here's an example of a CT scan of the peripheral vascular disease from a patient, 85-year-old woman. She had multiple risk factors. She had a CTO of the proximal anterior tibia, which you can see there on the angiogram in D. Note negative remodeling there was minimal calcification, and there was an occluded ATA with really not very much underlying atherosclerosis, and the etiology was thought to be an upstream calcified nodule. I'm not showing it here, but there was a calcified nodule upstream which we thought had embolized, causing the chronic total occlusion. Now this is another example, similar thing, where in this lesion, the SFA in B had evidence of a plaque rupture. As you can see, it's almost an occlusive lesion with a large thrombus there. And you can see down below in I and J, there's a CTO lesion with very minimal underlying atherosclerotic disease. So this was thought to be an upstream rupture with embolized thrombus causing a CTO downstream. This is not uncommon, as I showed you in the study. What about calcification in humeroperipheral arteries? You can see here types of calcification, intimal versus medial. You're probably familiar with this. You can see here that in this particular study of CLI patients, you can see atherosclerotic calcification in the intima was more common above the knee than below the knee, but medial calcification really didn't differ between above the knee and below the knee. And the types of intimal calcification are what's seen in coronary arteries. You can see microcalcifications, fragmented calcification, which are larger coalescence of calcification. You can see sheet calcification or nodular calcification. These are the different morphologies. Medial calcification goes into the similar aspects: microcalcification, fragmented calcification, sheet calcification, and nodular calcification, except this is medial calcification. And you can see here, there's a good correlation between percent stenosis and intimal calcification, which is thought to be an atherosclerotic disease. As you get more percent stenosis, you get more intimal calcification, whereas medial calcification really doesn't track with percent stenosis. It seems to be similar regardless of percent stenosis. And you can see we showed that here, intimal calcification assessed was significantly higher above the knee than below the knee in this particular study that we had done. And the extent of medial calcification was really similar above the knee and below the knee. So in summary, intimal calcification is frequently observed in both coronary and lower extremities, is more common above the knee. Medial calcification is also observed, and higher in diabetic patients' renal failure. And in patients with symptomatic PAD, thrombotic events are essentially seen above the knee and it's thought to be embolized. Below the knee vessels with CTO lesions frequently occur secondary embolic, either from atherosclerosis or emboli. And medial and intimal calcification do not allow good vessel preparation, and the penetration of drug is often hampered by the calcification after DCB. Use of systemic anticoagulants, I didn't review that here, but is especially useful in subjects with CLI and can really prevent amputations and further worsening. Better risk stratification of individuals at risk is needed to prevent atherothrombotic events before they occur, perhaps using genetic risk factors, etc. Thank you.
Thanks very much, Dr. Finn. I think to try and stay on time, we'll just go to the next presentation and save questions for discussion. So the next presentation is from Dr. Ahn from Severance Hospital on how he manages long femoropopliteal artery CTO with endovascular therapies. Welcome.
Thanks, Chairman. My topic was long CTO with endovascular treatment. The long CTO is not infrequent cases and unpredictable with a large thrombus burden or arterial burden, and easily recur due to the various mechanical causes and relatively difficult to complete true lumen wiring. Usually we use some bidirectional approach to the IVUS guided, or sometimes benefit for some the true lumen wiring. And my main decision for some the long CTO wiring was from the proximal stump positive, so we uses the anterior wiring first, and then the distal puncture with reverse cut. If there are no stump, the distal puncture first, and then distal guide wire, some guided anterior hard wire targeting was some first choices. If there are heavy calcified region, we usually use a bidirectional approach with reverse cut, and if there are some minimal calciums with a thrombotic appearance, the ultrasound guided wiring or simple microcatheter based wiring. And there are sufficient distal stump. We usually use your portion, but the poor distal puncture site, we changes the portion fork leg position with or some BTK puncture with 08 or 14 microcatheter supported bidirectional approaches. And scaffold or not, also usually it's a complete true lumen wiring or not. If there are some subintimal wiring, there are uses usually DES or some, and true lumen and mixed wiring, usually DCB or DS accompanied by the beta outstanding. Microcatheter management was very important for some the true lumen wiring or some subintimal approaches. And sometimes the microcatheter itself was penetrated to some long region. And durable workhorse wire was available in many companies. Some workhorse wire was high torque command or 18. It's usually short tip was for some subintimal and long tip was for long navigating method. So subintimal was usual some traditional method for some long CTO. If there are some guided stent or calcification, we can use the subintimal with the 035 wire. And sometimes the 035 was not easily penetrated. We changes the 018 or 014 wires for penetration for subintimal spaces. And reverse cut was also a very popular technique for some long CTO. So initial integrate wiring and subintimal spaces narrowing, ballooning for some and then retrograde wiring was possible for some complete some wiring of long CTO segment. Sometimes integrated decompression of some ballooning was can make a more some easily penetrated retrograde wiring. It's a 65-year male with some poor wound recovery after the trauma histories. And the left ankle Barker index was 0.57. And the CT shows is a long calcified left SFA total occlusion. And the minimal stump was visualized at the CT scan. And integrate wiring first by the microcatheter support. And the microcatheter supported anterior wiring was some difficult to penetration. And then we changes the distal puncture with ultrasound. It's very short, some landing zone. However, we changes the frog leg position, and then O14 based retrograde wiring was performed. And then the proximal and distal reverse car technique was performed by this calcification marker. And then finally, the ballooning to the proximal portion can make wiring to the proximal portion. And then the balloon and then stenting, DS, was performed for some final angiogram. So, that cases was a very long cases. First, the right side was a long segment. It's a very poor stump. And anesthesis was contralaterally approached, and distal puncture first. And then the retrograde wire was not passes through easily. And we bidirectionally subintimal and intraluminal retrograde wire was performed for this region. And then finally, the hard wire was penetrating to the distal portion. And left side was also some not a long CTO, but it's also CTO. So penetrating the anterior wiring first, but it's very difficult to wiring. So we changes the frog leg position to popliteal puncture, and then retrograde wiring with a bidirectionally reverse car technique was performed, and then final wiring was performed, and then we put the stent or atherectomy. And sometimes the EVUS was a very good some method for the long, especially in light side CTO. So it's a fluoroscope, very vulnerable portion. So it's a first assistant sonographer or assist sonographer was make some from the imaging visualizing to light SFA, and then the tracing the wire with a microcatheter and then some hard wire, and it's a relatively long, short, not a long CTO, but it's a microcatheter was well visualized in the SFA region, and then the wire was some tracing with the EVUS finding, and then total occlusive region site was penetrated by the EVUS guided wiring, and then IVUS shows such finally good patent, some true lumen wiring, and then the atherectomy and DCB was performed for this patient. So in summary, the different approach according to the region characteristic was tried for the long SFA CTO, and learning curve and experience would be needed in the CTO penetration in any method, and less injury technique for further procedure chances. And then the time and radiation and operator fatigue should be considered, and let's try for the SFA CTO penetrations. Thank you for kind attention.
Thank you, Dr. Ahn, for that excellent presentation. Next speaker is Dr. Jae-Hwan Lee from Chungnam National University Sejong Hospital, and talk about a very important topic, Guidewire and supporting device selection for BTK interventions. Welcome.
Thank you, John. This is my personal selection of Guidewire supporting device. As you know, overcoming coronary burden on crossover CTO, augmentation of guiding support, region modification, sometimes retrograde approach is needed. It's the same for the BTK, very calcified CTO region. If lateral approach is usually better, and sometimes we need a mother-child technique. Region modification is sometimes needed is the BAM technique, rotablation, external piercing. And most common things to overcome this BTK calcified CTO is a retrograde approach using a transpedal or pedal parental loop access, and sometimes bed form technique is needed. For selection of ipsilateral approach, some operators use short sheaths, but I seldom use this sheath because the contrast is more needed, image quality is poor, radiation hazard is more, and support power is poor. So sheath tip should reach P2 or P3 level. So you have to use 45 or 55 centimeters long sheath. If you use ipsilateral integrated approach, I usually use Anseropolis, and sheath diameter selection depends on the BTK lesion. If the simple BTK lesion, 5 French is enough. If you want to treat SF8 simultaneously, or if you try to use a pedal parental lobe access or difficult BTK lesion, you may use 6 French. For 7 French, femoropopliteal atherectomy is combining procedure. You have to use 7 French. Pedal parental lobe access, you need a long over-the-wire balloon or microcatheter supporting system, and micropuncture stent is recommended for safe puncture for ipsilateral integrated approach. So ipsilateral integrated access is the usual route for difficult BTK approach or pedal parental lobe technique. Contralateral femoral approach can be performed for the simple BTK lesion with 80 or 90 centimeter long sheath. 5 French for simple BTK lesion. If you use 6 French, you can treat SFA together, or complex BTK lesion, you need 6 French. Or for 7 French, you can treat iliac lesion together, or femoropopliteal atherectomy. But if you use a contralateral femoropopliteal approach, this over-the-wire balloon system or over-the-wire system reach the tip of the pedal arteries, but additional integrated route is required for the pedal parental lobe access. So contralateral access can be applied to the simple BTK case. This is summary of access route for BTK CLI intervention. Contralateral approach, you can treat ischemic heart disease or aeroiliac disease together. Puncture is easier, breathing complication less, but poor support. Backup support is poor, guidewire manipulation is not easy. So, and the additional route is required for the pedal parental lobe access. So, this contralateral approach is usually applied for the BTK region is less difficulty. Ipsilateral integral approach at puncture sometimes very difficult in case with significant common femoral or proximal SFA disease. Breathing complication is more. But this is applied for more complex BTK lesion such as calcification, thrombus field, required atherectomy, pedal parental lobe access technique. For hemostatic valve for sheath, there's 2 types of valve sheath, pre-mounted hemostatic valve system or TOE-BOS type Y connector. This is a removable or fixed design. This is simple for use, but I frequently use the 10 OK Y connector. Lock often feature system is a maximal 10 French in diameter. So multiple devices can be applied simultaneously. You can minimize blood loss with this cap system and easier removal of air and clot, easier retrograde wire sterilization. So I frequently use this system. Guidewire tip should be it's a distal tip, but it's very short. It's like a CTO intervention. And microcatheter backup is mandatory for rapid wire exchange, wire reshaping, super selective angiography, and increasing tip load. I prefer to use all 14 compatible system for BTK. Nowadays, my default system is not microcatheter, it's just Almada XT over-the-wire balloon, over-the-wire system. It's very helpful for balloon anchoring to increase guidewire power and progressive dilatation for calcified region. This is my guidewire selection for BTK and PTA CTO intervention. For initial step for integrated intraluminal approach, hydrophilic polymer jacket guidewire with superior steerability is my first choice, Gradius or Regalia. And you can use a transient shift to intermediate or stronger one for calcified spots such as Halberd or Astato. For subintimal tracking or retrograde approach, usually subintimal tracking is required for retrograde access. So Commander ES guidewire is my default wire. This is Guidewire character has a tip break resistant reshaping in situ without microcatheter is possible, a better handling for externalization. For intentional tracking or reentry of flush occlusion, I use Astato. And intraluminal approach super speed drawing with a hydrophilic guidewire is my default. And like this long CTO region can be also managed with just a guidewire passage with over the wire balloon backup, result is good. If you fail integrated approach in endoluminally or in subintimally, you may rapidly switch to the retrograde approach from the transfemoral access. So because coronary CTO, you cannot puncture the coronary artery, but peripheral artery, you can easily puncture at any site of the lower extremity. So there is a short needle and sometimes long needle is required. If the vessel is a little bit deeply located, such as distal SFA, P3, proximal ATA, peroneal, you need a 7 cm needle. And if vessel is superficially located, you can use 4 cm, is more easier to handle. And for the retrograde pedal access tools, I frequently use, I never use a sheath approach. Sheath approach is better to control breathing. My default system for retrograde access is a Command ES guide wire or 014 guide wire and 90 centimeter short CXI microcatheter. I want to share one case. This is a very calcified proximal ATA CTO case. Seems to be very easy case. Not so long ATA CTO guide wire passage was very easy. But Armada XT over the wire balloon passage was failed. BAM technique was failed. Guide extension technique also not successful. Guide extension plus Corsair is also unsuccessful. So I did a retrograde dorsalis puncture and retrograde wire was passed. But still, after externalization of guide wire, still balloon passage was failed. So at this moment, you may apply a bed form technique like this simultaneous movement of guide wire and over the wire balloon together. So remove friction between the wire and the balloon, so make an easier delivery. So it was so difficult, so I applied external piercing, then lesion was passed. So this is conclusion of my lecture. Selection of guide wire and supporting device of BTK intervention. Delivery systems must arrive at P2 or P3 level. Microcatheter guide wire selection is according to the region. 014 guide wire, inches guide wire is appropriate. And over-the-wire balloon system should be needed. Sometimes guide extension, piercing, better form rotablation required, but you have to apply retrograde pedal access or pedal plantar loop access freely. Thank you.
Sorry, my mistake. I was a little jumping the gun there. Our next speaker is Dr. Jen-Kuang Lee, who will present on multi-center analysis on safety and efficacy of BTK Everolimus-Eluting stent. Welcome, Dr. Lee.
Thank you. Ladies and gentlemen, so my topic will be a multi-center study on safety and efficacy of BTK, the Everolimus-Eluting stent from Taiwan. So this is our daily practice and the daily routine for the BTK intervention. As you can see, the lesion is very long, the vessel is very long, and the procedure time is very long. So it's our daily practice. But the procedure time is long, but the patency is short. So it is 1 month later. As you can see, the anterior tibial artery, as we work hard to revascularize it, but 1 month later, it disappear, and also for the 2 months still, and even for the 3 months still, the simple lesion, the proximal PTA and the proximal ATA still occluded or stenosis. So the BTK is equal to the calcify, the long, and the CTO lesion like this. This is severe calcify, the long lesion, and the chronic total occlusion. So as an endovascular interventionist, I believe all of you will agree this idea. So from the EDA Sensei study, so there's 40% we need to do the repeat endovascular therapy within 1 year, and the restenosis at 3 months is 70%. And surprisingly, the early recoil is about 15 minutes just after you perform your total occlusion for the balloonary lesion. So don't be happy just after the endovascular therapy. If you can wait for another 15 minutes, you can check angio again. So currently now is the era of drug coated balloon. We believe that. So every company have very good data for Femoropopliteal. But how about below the knee lesion? So let's conclude with this study. Is the study that conclude a lot of clinical trial or core study to make sure the DCB in the below the knee. So as you can see, maybe from the freedom from TOR, there's a little improvement compared to the PTA alone. But for the major amputation and the amputation-free survival, that's equal to the PTA. So what is the main idea for below the knee intervention? Our idea should be the major amputation and also the amputation-free survival, not only for the freedom from TOR. That's the main idea for the below the knee intervention. Also, calcium limits DCB efficacy. So as we know that the below the knee lesion always a lot of calcification over there. Restenosis, how to overcome this issue? So there's two issues that we need to clarify. The first thing is neointimal hyperplasia. The second thing is the recoil and the negative remodeling. So both of these from the idea of coronary artery disease, the drug-eluting stent should be the choice that we are going to achieve. So that's idea from our country that we want to do this Performance Premier. It's the BTK stent system. Although there's a lot of stent that can be used in below the knee, but to the regulation that in our country, only the Performance Premier get the approval for the below the knee intervention. So the key components for the drug release and for the recoil. So it's a multi-center Performance Premier BTK registry. So there's about 7 hospitals, a lot of PI that get involved in this study. So the main focus is the efficacy and the safety of the DS. Currently, in this study, we focus on the Boston Performance Premier in COTI because currently, if we want to treat below the knee lesion, the main idea is COTI. And we also restrict the stent amount use because we don't want to put all the stent from pop to the dorsalis. And we just check the outcome for half a year because these patients are COTI patients. So this is the result. Currently, we enroll about 84 patients. The age is about 72. And in our country, in Taiwan, the prevalence for the CKD and the ESRD is quite high. So the calcification and the recoil can be appreciated and predicted. So the intervention of the BTK, the prevalence, you can see the ATA, peroneal, and the PTA. ATA get a lot, the most amount for the intervention, and the CTO get about 61 patients. We rarely use the intravascular image due to the reimbursement issue. And below the knee portion, since we are going to put the stent to this patient, so most of the patient is put to the proximal, to the middle part, not for the distal. The size, also in our country, maybe it's the general idea for the Asia country. The size is about 3 millimeter. The length is about 73. So the patient may have concomitant lesion about SFA and iliac. So ABI improved from 0.3 to 0.8. Fortunately, all of patients don't have the major amputation and they don't have the all-cause mortalities. As we know, the issue for the drug DCB, the mortality issue. So this patient don't have the mortality. So I like to show some cases. The first one is 78-year-old man, dialysis, loose flow class 5. So this is the pre-EVT. And lesion is here, but it's very ugly like this. If you can see, trace the lesion is about this. So finally, I can retrograde, puncture this area, and to recanalize it, and put a stent here is the final angel. And this is another patient, the 86-year-old woman, also the dialysis, loose flow class 5. there's a CTO segment over here. So after recolonize, we put stent here. And this is the last case. It's not only the calcification over the SFA, but over the below the knee, the total occlusion. So not only the pullback, but also we do the rotabulation. Even after the rotabulation, still, finally, I still put the stent over this area. So stent can overcome the calcification and the total occlusion. So let's see one case. That's the clinical scenario like this at 3-6 months. So this is our take-home message. Below the knee lesion is difficult to maintain even short-term patency. So this is due to the calcification, long lesion, and the chronic total occlusion. Currently, DCB is not the savior in below the knee lesion. It's from the RCT, meta-analysis, real-world data, and the personal experience. DS may be the game changer. In this study, we use the performance premium, but still a lot of issues we need to clarify, including the location, length, radial force, and the long-term result. So let's fighting for the limb salvage. Thank you.
Thank you for your data about the DS and BTK area. So next speaker is John Laird. So he's going to talk about my 30 years story caring for a patient with symptomatic vascular disease. Dr. Laird, please.
Well, thank you very much, and good afternoon, everyone. When reflecting on my past 30-plus years of peripheral intervention as a cardiologist, I couldn't help but think about the people that helped me along the way, including my early mentors, Dr. Christopher White and Stephen Ramey and Tyrone Collins at Walter Reed Army Medical Center, who were my mentors during my cardiology fellowship and first introduced me to peripheral intervention. And then the group at the Washington Hospital Center and Cardiovascular Research Foundation, who are my colleagues and mentors in my early years as a practicing interventional cardiologist. Doctors Gus Bichard, Marty Leon, Lowell Sadler, Kenny Kent, Ron Waxman, Jeff Popman, Gary Mintz, amongst others who helped support me during my early career. During my cardiology fellowship from 1987 to 1990, it's hard even to think about it, but there was only balloon angioplasty. There were no FDA-approved stents or other devices. We did not have dual antiplatelet therapy at that time. Our technical success rates were only 80 to 85% with balloon angioplasty. There were problems with acute dissection and elastic recoil. We had acute vessel closure occur in 3 to 8% of cases, often with significant consequences. And there was a need for emergency backup bypass surgery in 2 to 5% of cases, with restenosis rates, if we were successful initially, of 30 to 50% with balloon angioplasty. So those good old days were really not so good. And so there was a lot of enthusiasm about the new devices that were introduced in the early 1990s, including the atherectomy devices and stents. What about the state of the state with regards to peripheral artery angioplasty at that time in the 1980s? Well, again, only balloon angioplasty was available. And if we look at the balloon angioplasty results in the iliac arteries, we see better results, probably in large part to due to the size of the arteries, with 1 month clinical success in around 90% of cases, but significant drop-off in patency over time related to restenosis and to disease progression in the iliac arteries. So there was great enthusiasm when the stent era began in the 1990-1991 time frame. This was the original Palmaz 308 iliac stent, balloon expandable tubular slotted stent that was 30 millimeters in length and could be expanded from 8 to 12 millimeters in diameter. I actually attended the first Palmaz iliac stent training course in San Antonio, Texas in 1991, where I first met Dr. Palmaz. This is actually one of the slides from that training course showing the equipment that you would need to perform iliac stenting. We needed 10 French sheaths at that time, which was a real problem for patients and doctors in the pre-closure device era, particularly when you're doing bilateral iliac artery stenting. And there was a crimping tool to crimp the stent onto the balloon to try and ensure that the stent would not slide off the balloon as you advanced it through the valve in the sheath and through the diseased arteries. But there was really good results in that early experience with the Palma stent. This was one of my very first cases that I treated at Walter Reed Army Medical Center with both excellent angiographic and hemodynamic results. And over the ensuing years, we saw continued improvements with our stents, both balloon expandable stents, self-expanding stents, and covered stents for iliac artery use. And with good technique, as demonstrated in this paper from Japanese group from a few years ago, using intravascular ultrasound to guide iliac artery stenting, the long-term results are really remarkably good. With 15-year patency rates, both primary patency rates and secondary patency rates that were excellent. Secondary patency of over 90% at 15 years with iliac artery stenting. So we can treat very complex cases such as this with chronic occlusions of both iliac arteries. In this case, approach from a left radial artery approach, a one access, able to cross occlusions in both iliac arteries and treat with stenting with a very nice angiographic and hemodynamic result. Very extreme cases such as this, heavily calcified aortoiliac arteries with occlusion can now be successfully treated with, in this case, covered stents with excellent, again, angiographic results and good clinical outcomes. So we've gone from an era where an aortobifemoral bypass was a very commonly performed procedure to an era where it's a very rarely needed procedure because of the excellent results we achieve with treatments in the iliac artery, endovascular treatments in the iliac arteries. We've been much more challenged in the SFA due to the nature of the disease in the SFA, diffuse long lesions, heavy calcification, associated disease of the infrapopliteal runoff vessels, and then the complex mechanical forces which complicate placement of endovascular prostheses. Because of these challenges, we've seen a whole host of different technologies, multiple different balloons, hot balloons, cold balloons, cutting balloons, scoring balloons, serrating balloons, and then more recently drug-eluting balloons. There are a whole host of CTO devices that have been developed, laser and atherectomy devices, and a variety of different stents, including a standard laser-cut nitinol stents, covered stents, woven nitinol stent, and most recently paclitaxel-eluting stents for the SFA and popliteal arteries. But probably the biggest advance that we've seen in my lifetime of doing procedures in the SFA has been the advent of the drug-eluting balloon. This was the initial paper from 2004 by Scheller and Speck, who were able to demonstrate that if you took paclitaxel and mixed it with iodinated contrast, you could then coat a balloon and allow the paclitaxel to come off the balloon and effectively deliver drug into the vessel wall to inhibit subsequent neointimal proliferation. I was one of the co-principal investigators for the IMPACT SFA drug-coated balloon trial, where we saw at 3 years by duplex ultrasound dramatically better results with the IMPACT Admiral drug-coated balloon standard compared to standard balloon angioplasty. We learned better angioplasty techniques because of drug-coated balloons, using long balloon inflations, appropriately sized balloons, avoiding geographic miss. We can see really outstanding results, even in complex morphologies in the SFA and popliteal arteries. And we now have data out to 5 years from the randomized trial, as well as the global registry, showing sustained benefit with this IMPACT Admiral drug-coated balloon for complex lesions in the superficial femoral artery. We have better devices for calcium, atherectomy devices that can be used. In this case, a very complex calcified lesion in the femoral bifurcation, treated with HAWK1 atherectomy, followed by drug-coated balloon angioplasty. We have the woven nitinol stent from Abbott, the Supura stent, which is a really excellent stent for complex calcified lesions, particularly in the popliteal artery, where if we use proper technique, we can get outstanding results and good durable results. And more recently, we have shockwave intravascular lithotripsy, which has been demonstrated to be effective in multiple vascular beds, including the SFA and popliteal artery, as noted in the DISRUPT PAD-3 study, less need for stents and better patency when shockwave IVL was used. But probably one of the most exciting advances, again, over the past 30 years has been the significant improvements in techniques for limb salvage in patients with complex infrapopliteal occlusive disease, distal and multi-vessel intervention, pedal and tibial access, advanced CTO techniques with cart, reverse cart, and rendezvous techniques, recanalization through collaterals, plantar arch recanalization, and more recently, transcatheter arterialization of the deep veins. 25 years ago, it would never have occurred to me to puncture one of the distal pedal vessels to try and do a retrograde crossing of tibial occlusions, but now that's become commonplace. Difficult cases like this can be handled very readily with a bidirectional approach, tibial puncture, crossing from below, and treating from below and above to treat very complex disease with really outstanding results. And I think we sometimes forget during our very, very busy daily lives of treating complex peripheral artery disease, particularly CLI cases, the impact it can have on our patients' lives. And I would just like to finish with this one case to illustrate the gratifying results that we can achieve for our patients. This was a 67-year-old male that I treated about 10 years ago, long-standing diabetes mellitus, peripheral artery disease, had a large non-healing ulcer on the plantar aspect of his foot and was unable to walk. He had had a failed attempt at revascularization at another hospital and was told he would likely need below-the-knee amputation. He came to me for a second opinion, had sort of the typical anatomic substrate with occlusion of all three of his infrapopliteal arteries. We're able to cross occlusion in the perineal artery and the anterior tibial artery from above. Not really a particularly complex or difficult case, did not need bidirectional approach. We performed laser atherectomy followed by balloon angioplasty with really nice angiographic results and good flow into the foot at the end of the procedure. He was able to heal up his wound by 6 months and was returned to normal activities of daily life. And then I kind of lost track of him for a little while. Didn't see him back for several months. And then I got this letter addressed to me from somewhere. I didn't actually recognize where this was from the postmark. I think you all could help me with that. But this letter arrived, and it was from my patient. Dear Dr. Laird, gasping for thin air and standing wobbly on the two legs that you and your good work preserved for me, I stood at the base of Mount Everest today, a thing I had hoped to live to see since childhood. I couldn't let the day end without thanking you for your skills and care that led me here. You know, when you're first confronted with the very real and probable possibility of losing my leg, my true horror was not over becoming an amputee, but in the end to travel as I have experienced it. And this was a photo that came with a letter of my patient Tom during his trek in the Himalayas. And it just highlighted to me the importance of what we do for our patients, how significant an impact it is to save someone's leg, and how important this work really is. So thank you very much for your attention, and thank you to TCTAP.
Thank you very much. Yeah. So we'll have 10 minutes discussion time. So is there any comment?
First answer is China, Shanghai.
I have a question to Dr. Finn. So you gave us important insight into the different pathology, involved in the development of PAD according to the site. So since the BTK lesions have different pathology than the above the knee lesions, do you think we need to apply different treatment strategy there?
That's a great question. That was the question I was going to ask. What should we be doing for these below-knee lesions since you've identified this different pathology?
Well, you know, I think that the two answers are, one, medical therapy. I think we showed that a lot of these are embolized thrombi that occur and occlude. And so, you know, it's been shown again and again, rivaroxaban, other trials, that anticoagulants, when they do have bleeding risk, are very effective at preventing lower extremity ischemia and CLI amputation. So I think that's one thing you can do. Another thing is, I don't know how well intervention is going to do in these lesions, because really we're dealing with sometimes sites that are upstream. I showed 50% are atherosclerotic, but even other studies have shown less than 50% are atherosclerotic. They're embolic. So, you know, opening that up, yes, you take care of the acute lesion that's closed, but you're not taking care of the potential for further emboli coming upstream. So I think, you know, this is the holy grail down a BTK, is why hasn't anything worked well? I don't have any other thoughts on that, but I'd love to know your, you know, thoughts, because I really don't have a good answer, except for I think medical therapies may be more effective once you recanalize these lesions.
If you look at the lesions, do you have any kind of clue as to what anti-restenotic therapy might work better, paclitaxel versus Alimus drugs, based on the pathology of the lesions? Anything
Well,
there?
I mean, the issue, I think, is that these medial calcification tended to be not that different between above the knee and below the knee, and intimal calcification was much higher above the knee than below the knee. So calcification, although it's an issue, I don't know how much of a huge issue it is, and more of an issue for, I think, above the knee. In terms of drug-eluting technologies, I mean, I think balloons might work. We discussed this morning that I think that this paclitaxel balloons do have advantages. The drug transfer is good. But, you know, these are slow flow individuals already with impaired flow downstream, unable to regulate it well. There's always the issue of emboli, paclitaxel emboli, amputation, you know, increased risk. Sirolimus, yes, better drug, probably less chance of embolic debris, but is the anti-restenotic effect sustained and as good as it is with paclitaxel? I don't think at this point we have a technology that's really going to be good enough to really result in sustained patency of those vessels at this point.
And following this question, I want to ask about a kind of clinical practice. So some doctors will, when they deal with the totally occluded artery, after penetrate the artery, they did not do the balloon dilatation, but they did not see any thrombus. They just do the give the urokinase maybe through the fountain catheter, maybe for 10 or 20 minutes. But they did not say the urokinase is for the patient or for the doctors, because they just worry about distal embolization. So from your point of view, is it a reasonable clinical practice?
Well, I mean, I think what we showed in this is, if it's an acute occlusion, yeah, I think it's reasonable to recanalize thrombus. But what we showed is that a lot of these thrombi are organized and old and fibrotic. And so when you see an occlusion, if you're going to give urokinase, if it's already organized thrombi, it won't be very effective. So I think it really depends on, and a lot of these I don't think are caught. I think a lot of them, you know better than me, a lot of them are caught when they're already embolized and been closed for a while. That's one of the problems here. We don't catch these occlusions quickly unless they're multi-vessel occlusions and all the legs, all the vessels are occluded.
That's great, thank you. I have a question for the panel, and this is kind of based primarily on Dr. Ahn's presentation. Do we still, at this point in time, have any good knowledge about whether we need to stay true lumen when we're crossing long femoropopliteal CTOs? Does it really make a difference in terms of patency if we go subintimal or remain true lumen? Anyone want to take this one?
But I think the main problem is that when a wire crosses a lesion, if we do not do the EVARs, we cannot make 100% sure it is totally true lumen or partially subintimal. So it's very difficult to say that.
In my experience, I don't see any big difference in the outcome, between intraluminal approach or versus subintimal approach. I think the DCB works very well also in subintimal space. So in that sense, I think so you don't have to make a big difference between intraluminal approach or subintimal approach.
Okay, thank you. Because of the time limitation, we'll move on to the next topic, so aortic aneurysm. First speaker is Ki-Hyun Chun, working for Seoul National University Bundang Hospital. He's going to talk about recent update of long-term outcomes after surgical and endovascular AAA repair. Dr. Chun, please.
Thanks, Chairman, and good afternoon, ladies and gentlemen. I am honored to be able to give my presentation after such a great lecture of Dr. Laird. So I'm going to talk about the topic titled Recent Update of Long-Term Outcome After Surgery or Endovascular AAA Repaired. I have nothing to declare, and this is my contents. So, as you know, over past 20 years, the EVAR has been replacing open surgical repair as the preferred treatment for AAA. As you can see, the dramatic decrease and increase of open repair and EVAR from 23 to 30 in US. And now, this is updated guideline released in 2022, the brand new ACCH guideline for aortic disease, which is emphasizing the importance of shared decision-making when considering the treatment of unruptured AAA in patients with low to moderate operative risk and suitable anatomy. So both open repair and endovascular repair are considering viable options such cases. And in case of ruptured AAA, the endovascular repair is recommended over open repair. And this is supported by the meta-analysis that showed EVAR is better than open surgery in terms of perioperative and overall mortality and acute kidney injury and early intervention for ruptured AAA. So I would like to introduce the landmark trial that compare long-term outcomes of open endovascular repair of AAA. This is DREAM trial that showed EVAR was better than open surgery in the 30 days mortality, but in long-term mortality there was no difference between open surgery and endovascular repair, and the reintervention rate is increased in the endovascular repair group during a longer-term follow-up. And this is long-term follow-up of EVAR trial 1. And this trial showed while there was no significant difference in mortality between two groups, but EVAR was favored in early years after randomization. However, beyond 8 years or 10 years, the open repair is associated with lower all-cause mortality and aneurysm-related mortality. And this is another result, RCT, the most recently published RCT over trial. The 400 patients each group and median follow-up was 8 years. There is no difference in mortality between two groups, and unlike previous study, there was no difference in death rate according to the time from randomization. So they explained that the over trial began several years after previous trials. So there was an evolution in EVAR device and technique, and especially they use lower dose of radiation that associated with cancer-related deaths. So let's go to the meta-analysis that includes 7 randomized trials, including ACE, DREAM, over, EVAR1, and so on. In short-term mortality, the EVAR has definite benefit over open repair. But the time goes by, the benefit is tend to be neutral or even slightly favor open surgery. And this is recently published large cohort study, retrospective cohort study from US, analyzed data from the VQI vision database, including 28,000 of EVAR patient and 4,000 of surgery patient. After propensity score matching, the analysis of nearly 3,000 paired patients, the study found that in terms of long-term mortality and the intervention rate, the open repair is better than, significantly better than EVAR in long-term mortality. But this study is retrospective study, so therefore it has some limitations such as the off-label use of the EVAR device or non-adherence, the long-term surveillance recommendation, and not available the aneurysm-related death data. But now we have another registry data using the advanced stent graft. It showed promising data. The engaged registry present long-term outcome of advanced stent graft. It showed that freedom from reintervention rate was 8% at 5 years follow-up, is improved from the 70% of previous DREAM trial use older stent graft. And additionally, recently announced 10 years data that also showed acceptable long-term durability of this advanced stent graft. So this is my conclusion. Despite the early benefit of survival, long follow-up of this trial shows similar mortality between EVAR and open surgery. In recent meta-analysis and large cohort study of EVAR versus open surgery for AAA, long-term outcomes show mixed result. The significant advances have been made in EVAR technology over the year, including graft design, deployment technique, and imaging modality. So newer generation endograft with long-term follow-up are needed to better understand the outcomes of modern EVAR. So as guideline emphasized, the shared decision-making between interventionist and surgeon or patient is crucial in selecting the most appropriate treatment option for the AAA. Thank you very much.
Thank you for that great presentation. We'll have a follow-up presentation on a similar topic. Dr. Ko will talk about whether EVAR is safe and durable in the long term.
Thank you for the kind introduction. So I realized that my talk overlapped a little bit with the previous topic. I would like to start out with the two cases treated with the EVAR. So 66-year-old male treated with the EVAR in 2010, and over the 10 years, the aneurysm sac remained stable. However, after 10 years, the aneurysm sac started to expand. So we suspected the type 3 endoleak, and we treated the right limb with stent graft reinforcement. And however, the aneurysm sac continues to grow. So this patient underwent surgery. Another case, 65-year-old male treated with EVAR using FX2 in 2017, and the aneurysm sac remains stable up to 4 or 5 years, and then as you can see on the CT scan, the upper part and the lower part of the stent grafts, the overlap to the stent grafts are separated, and the aneurysm sac began to expand. So in this case, we did reintervention with another stent graft. So this slide overlapped the previous presentation. So EVAR-1 long-term follow-up data was released, and overall total survival and aneurysm-related survival did not show any significant difference. However, total mortality beyond 8 years increased in the EVAR group, and also aneurysm-related mortality increased in the EVAR group beyond 8 years. So this shows the inferiority of the EVAR compared with the open repair. And also the survival free from any re-intervention or life-threatening intervention was lower with EVAR compared with open repair. This is meta-analysis. So in short term, up to 6 months, there is a favoring EVAR in terms of all-cause mortality and aneurysm-related mortality. However, in long-term follow-up, beyond 4 years, the outcomes in terms of all-cause mortality and aneurysm-related mortality, the favors the open repair. Again, this is the same the paper. This engaged registry investigated the outcomes of the Endurant device, which is, I think, one of the most commonly used device for the treatment of EVAR. And the initial cohort has 1,263 subjects worldwide. And this part of this cohort was followed for 8 years and recently up to 10 years. And this study showed excellent outcome of the Endurant device. The aneurysm-related mortality was only 0.5%, and the secondary endovascular procedure was about 25% at 8 years. I think this is excellent performance of the device. And type 3 endoleak is only 0.8. And main body migration is also 0.8. I think this shows the durability and safety of this device. And as you can see here, the shrinkage of the aneurysm was observed more than 60% at 8 years. And there is an increase in SEC dimension in 14% of cases. These patients required the reintervention. Overall, I think this data demonstrate excellent outcome, excellent performance of the recent EVAR device. This study compared the EVAR 1 ICT, the EVAR arm with the outcome of ENGAGE registry. This shows that better performance of ENGAGE study, so the recent device, in terms of freedom of aneurysm-related mortality and freedom from reintervention. And aneurysm-related mortality rate, was decreased with the use of the recent device. This is U.S. Medicare data, and this shows again the open repair performed better in terms of all-cause mortality and rupture and aneurysm-related reintervention. And this study look at the temporal trend of the outcomes of the open repair and EVAR. We assume that the recent device may perform better than the old one. However, in this analysis, this could not be confirmed. So both early phase and the recent phase outcomes of the open repair or EVAR showed similar outcomes. And I think the impact of the IFU adherence is very important. And this study showed about 20% of cases showed characteristics outside of IFU. And there was a significant difference in the 5-year survival between the adherence to the IFU and non-adherence to the IFU. And also the type 1 endoleak and perioperative mortality, 1-year SEC expansion, and 1-year reintervention rates showed better outcome with the adherence to IFU. And it looked at the impact of different various hostile neck, the anatomic components on the clinical outcomes, and especially infrarenal aneurysm angulation and neck diameter had a greater impact on the outcomes of the EVAR. So such as endoleak, type 1 endoleak, and mortality and expansion rate. And so this study now in press showed that there is a continuous dilatation of aortic neck after the EVAR. So more than 50% of cases showed dilatation of the aortic neck after EVAR, more than 2.5 millimeter, and more than 5 millimeter dilatation was shown in about 30% of cases at 5 years. We checked our data. This is data from 2 centers. We had 766 patients from 2 centers between 2000 and 2021, and mean age was 71. And we found that our patient, about 60% of our patient had outside IFU, especially neck angle greater than 60 degree, and neck thrombosis or plaque more than 50% of circumference were the common factors of the outside the IFU. And endurance was the most commonly used device in our cohort. And we found that the aneurysm sac shrinkage in about 40% at about 4-year follow-up, and 24% of cases showed expansion of the aneurysm sac. Type 1 endoleak was found in 7%, and type 2 endoleak was found in 11%. And we found that adherence of IFU showed better freedom, higher freedom from aneurysm-related mortality. However, the mortality, overall mortality, and the reintervention rate showed no significant difference between 2 groups. And the neck diameter was the predictor for the aneurysm-related mortality. And this study shows the open conversion after EVAR shows the poorer outcome than primary open repair. So when we have a complex abdominal aortic aneurysm, we think about this fact, and we should consider to recommend open repair first. However, for the age between 65 and 79, the outcome of the EVAR and open repair was similar in terms of the overall mortality. However, in age less than 65, the open repair performs better. However, in the age of over 80 years old, the EVAR performs better in terms of overall mortality. So these are my take-home messages. Recent studies demonstrated aneurysm-related mortality during long-term follow-up is higher with EVAR than open repair, despite reduced 30-day mortality and perioperative morbidity after EVAR. Especially non-adherence to IFU was associated with increased incidence of reinterventions and aneurysm-related mortality after EVAR. Thus, EVAR should be primarily indicated for patients at old age or at high surgical risk after considering anatomic conditions according to IFU. Open repair should be considered for younger patients, maybe below 65, as first-line therapy. Regular surveillance after EVAR is important to detect early unfavorable adverse changes of aneurysm sac and implants after EVAR. Thank you for your attention.
Well, thank you very much. That was really a great overview. Last presentation of the afternoon by Dr. Kim from Cheonnam National University Hospital on is TEVAR safe and durable and long-term? Welcome.
Thank you, Chairman. My name is John Kim. My topic is TEVAR safe and the durability in long terms. But TEVAR history is just 1994 accepted the NEJ, and the 2005 is FDA approved, and the 2010 is enrolled the guidelines. So long term outcome is not available at this time. It is maybe the till we waiting for the 10 years. So and TEVAR is landing zone is very important. So type zone 4 TEVAR is very long term is good, but zone 0, zone 1, 2 is a very poor prognosis. Risk of the re-intervention after TEVAR is as time goes by. So some studies is 11% cases of the re-intervention, and the cumulative incidence the 5, 7, 14% in the 1, 3, 5 years. And usually the re-intervention in TEVAR is endolic. Endolic treatment is usually the re-intervention. Second is re-intervention is TEVAR is pulse lumen enlargement. Pulse lumen is the second indication. For my patient is 53 years old male patient and type A and aortic dissection, so operation to graft interposition. And then after 3 years, is the enlargement of the pulse lumen, but we decision the observation. After 8 years, there is more enlargement of the pulse lumen, so we do the TEVAR procedure. And then follow up after TEVAR is 1 year, so it's acceptable, but mild enlargement in the abdominal pulse lumen area. And 3 years after, this is abdominal area is more enlargement. So we do the motor processor. And at the time, the stable eye studies, we do the bare metal stent and the Viaband the stent graft in the renal artery. And then follow-up is good result for the abdominal aneurysm, abdominal pulse lumen. But after 3 years, the more distal is pulse lumen enlargement. So we decision the vascular probe to the two root and the EVAR procedure. So this is a vascular probe, and the two vascular probe is the pulse lumen the occlusion, and then the EVAR procedure, and the follow-up is a good result. First is endolic. This is a 76 male patient. The aneurysm that develops, so we do the TEVAR procedure with the debranching and the plug. It's a debranching and the plug state. After 1 year, developed the type 1A endolic, so we mode the extension to the proximal region with the Chul-Min technique. So this is a follow-up, is a mild type 1 endolic, but recommend observation, this state. And 6 months after, the more increased the endolic. So this first time and the first TEVAR processor, and at the time the debranching with the plug, and the endolic is so with the more redo the TEVAR with the Chul-Min technique, and then the increase the endolic, so with the helix endo-anchor procedure and good results. Second is this sign, distal stent graft induced new entry. So develop. This is a 75 female patient. This is first time is this graft interposition, and 5 years after this is enlargement of the pulse lumen. So we TEVAR procedure. This is graft interposition and TEVAR procedure, and after 3 years after this new entries development, so with more need to the TEVAR procedure. And 3 years after, this is a good result. Right? Follow up the CT is a good result. Sometimes the valve graft is mal design, or the material is failed, so we withdraw the stent graft system. But usually the long-term outcome is compared to the medical therapies is a good result. So acute aortic dissection is more result is long-term is outcome is good overall. So my case is initial is the aortic dissection, and after 2 weeks after TAVI procedure, TEVAR procedure, this is the zone, and the TEVAR procedure. And first is the result is good, and then 1 year after CT follow-up, this is no endolic and low sign, and 5 years after, this is a good result for the no endolic and the no sign. And last year is 8 year follow-up CTs is no endory and no sign. It's a good result. So long-term outcome of the TEVAR in the is compared to the operation is short-term is affected maybe the 1 year or 2 years is similar, but long-term for the 5 years is diverged and the more TEVAR outcome is poor. But survival is acceptable though. So my conclusion is that TEVAR has become the preferred approach for the patient with thoracic aortic pathology and anatomy amenable to the endograft placement. Educate the ceiling zone and careful the preoperative planning and the proper device sizing are critical to obtain the good result and limited complication. Thank you for attention.
Thank you. Thank you for your nice presentation. So we are a little bit behind the schedule, but I think the short comment question will be possible during the next 5 minutes. Okay. Dr. Go, so, do you believe that long-term durability of these recent stent graft will be effective in the near future?
I think since people live longer, so we need more longer follow-up. But I think the recent device shows very good durability and stability over the years. So I think definitely recent device will show better performance. However, the SEC aneurysm expansion does not always occur due to the malfunction of the stent graft, but such as type 2 endoleak. So I think we have some homework, to solve this problem.
Yes, I have a question to Dr. Laird. So in Korea, the excluder system is not available right now. What is it? I think it's a really ideal design for, especially in the TEVAR procedure. So because of it eliminates the bird beaking effect and also the sign, and do you think this core system has a different outcome compared to the other system?
Well, I think it is a good device. I think maybe the advantage is both for the EVAR device as well as TEVAR device is the conformability and perhaps a little less bird beaking than seen with other devices. For EVAR, it doesn't have suprarenal fixation, which I think is a limitation, a serious limitation for EVAR. But with the new conformable core device, it works still reasonably well in angled necks. And I do think that the iliac branch graft device has really been a really great addition to the armamentarium treating combined aortic and iliac aneurysmal disease. In terms of TEVAR, yeah, I think it is a good device because of the flexibility relative to the other devices that are out there.
Thank you. Is there any comment or questions?
I want to ask about one question for the asymptomatic patient. And during follow-up, the size is already fulfill the indication for operation. From the slide, say it needs a shared decision making. But in the real world, how high the percentage in your practice the patient, no symptom, really agree with the operation? Why I ask the question, because my uncle just died of this disease 1 month ago, but 6 months ago he already know the condition, no symptom, and regular follow at a vascular surgeon. And we also have shared decision making in Taiwan, but so I think SDME also creates some problem.
I think there's more to the equation than just kind of mortality rates and reintervention rates, because My mother had an open aneurysm repair when many years ago, and she was never quite the same, after the surgery. It's a big operation. Cognitively, she declined afterwards, and her quality of life was never quite the same. An aortic, open aortic operation is probably the biggest operation that any patient would undergo. And so there's for men, there's potentials for impotence and other related complications. So there's more to the equation than just mortality, and I think that has to be part of the discussion with patients when you're deciding open versus EVAR.
Okay, so thank you. I really appreciate all the speakers and attendees here. I'd like to close this session. Thank you very much.